the presentation of the staff report, staff survey last time, and my observation that primary care staff may find over the next few months that they have been very exhausted by all the work we're doing, and that we ought to be thinking proactively about how we might support them before we end up with people unable to carry on managing in primary care. So just to take the advice from Andrew and his team as to how we might support primary care before we end up with an issue.
Okay, that's great. All right, thank you. And then the last one, John, was for you to circulate details of levels of activity for the independent sector for a 4-week period, and that's been circulated. Yeah, okay, so both of those are for closure. Okay, Chair's report. I am going to take that as read. There are only 2 things I want to highlight, and one is around the ICS designation submission in item 3. And really just to express my thanks. I was part of the meeting, I was invited to be part of it, but actually the bulk of the work was led by Simon and the other chief executives, but Simon did do the bulk of the role of presenting and coordinating that meeting. And actually we were commended by NHS England regionally, not just in that meeting, but in other forums, for the coordinated way and the way that we described an integration journey and the way that we presented ourselves as a system rather than a collective of individual organisations. And that was a really positive comment to come back from NHS England, given some of the challenges that we faced as a system that are known to all of us. We were particularly praised for the work that we've done around providing mutual aid to other areas of the country, given the low prevalence of coronavirus within our system, and the way that we've done that in a coordinated way across our providers, and also in the way that we've run our Nightingale Hospital. And I think in that a particular thanks goes to Darren for the work that he's done and the team that he's worked with, and he's been part of it from its inception when it first had a patient 90 days ago to this point now, where we're getting to a point where we can maintain the care of our patients within our 4 acutes. So it's been a real success story. It served its purpose before COVID patients with the diagnostics, taking advantage of the facility there, and has served our population and neighbouring populations well in looking after patients with COVID. So thank you, Darren. Thank you to everyone who's been involved in it. And it was certainly noted by NHS England just how well we've pulled together as a system to make that happen. That was the first bit, and then the second bit I think is just around the still around integrated care systems, but I will not go into detail about that because I know in Simon's report there is more detail around some of the things that are present within the white paper that will affect us as an organisation, us as a system, but give us a genuine opportunity to work much more closely and to build on those collaborative relationships that we have within Devon. So I'm happy to take questions or comments. And that's great, in which case I won't take any and I will pass straight over to Simon for the Accountable Officer's report. Thanks, Simon.
Thanks, Paul. So again, I'll take this as read. There were a couple of items I just wanted to draw out. So in the building upon what you've said about the vaccination programme, so I'd like to record my thanks for the really good partnership working that we've been able to have on this programme, but under the leadership of Darren, as you mentioned, Paul, but also the support he's had from Karen Barry and a number of other people. At the time of writing, you'll note here that it says our county had more than 300,000 of our most vulnerable people had been vaccinated. That's actually in excess of 400,000 now, including over 96% of those over 80. So I think a phenomenal effort in a short period of time, and the programme is now seeing about or vaccinating in excess of 12,000 people a day. I think just completely phenomenal work, and could only been achieved through great partnership working. The second item is really just to draw your attention again to the corporate objectives that we agreed last month, but a reminder that we will bring a quarterly report on progress to Governing Body, and we will have our first one in April. But happy to take any questions. I've avoided the ICS Paul, because you've mentioned it. You know, we've had the white paper, but we're still awaiting some detail. But happy to take some questions.
Thanks very much, Simon. Judy.
Thank you very much, and I'm sure the rest of us on Governing Body, like Simon, would like to thank everyone that's done such a great job on the vaccination programme, as well as all the other COVID things. Simon, may I just pick up a point on your integrated care system proposals section? And in a way, this is a proposal to Governing Body. Simon, I noted that at the end you say we're discussing the proposals with our staff, which is great, and we will share more detail on the plans as they are developed. It feels to me that the nature of the change in this white paper and the introduction of the ICS and place is something that the governing body ought to be very actively involved in. And whilst we clearly can't discuss it at every single meeting in micro detail, I would like to suggest that we consider something like a small board working group or something that is involving some of those of us who are just involved in the governance side of things. So I wonder, Paul, whether that's something that we could either consider now or perhaps make a note of in the minutes and agree a way forward between this and the next meeting.
Judy, I think that's a really helpful point. I think what might be quite useful is, Nick, why don't you just, I know you have problems with your microphone, hopefully that's not the case now, but you were part of a similar sort of thing when we merged the CCGs that allowed that board level oversight, but actually didn't consume the significant amount of board level time. Just for those who weren't part of that merger, just sort of describe how that sort of thing worked, because it was a similar sort of significant organisational change that we went through. Are you on mute, Nick? I think you are. We might come back to you. Simon, your thoughts on that?
Yeah, so I completely agree. Paul and I agree, Judy. So I was discussing with Ginny and Adam Carrick this morning around some of the tasks that we need to fulfil. Obviously, we are awaiting more detail, but there's some work that we can be getting on with. So one of the things I was discussing with Ginny was how can we make sure that all the statutory duties of the CCG are, kept safe over the 12, 14 months transition period we've got, but that they find themselves in a suitable place in the new ICS structure. And again, I think that would be a really good place for us to have some non-exec involvement. We've agreed with Dame Susie Leather that there'll be a small working group that will come up with some proposals on what the governance structure could look like for an ICS. Paul, I think, has kindly agreed to join that from a CCG perspective, but it will only be a very small group that will come back with proposals. But I think you're right, Judy, that we need both the right time to provide our thoughts into a development programme, but also that we need to make sure that we have suitable levels of assurance over our statutory functions as they passport into a new organisation. We will, of course, keep monitoring the detail that comes through, but I think that's a very sensible suggestion, and quite happy to take some thoughts on how we would structure that.
Thank you.
Nick, are you with us now? Are you able to sort of give us a bit of insight of the learning that we had from what we went through, almost 2 years ago now?
Yeah, so the group was chaired by Tim Burke, the then chair of Devon CCG, and on it were myself, another non-exec, and Ginny's predecessor. And we simply monitored the project plan for the merger of the two CCGs on a kind of monthly basis, and we're just tracking to make sure that everybody who was involved in the merger programme was getting all the resources they needed to get the job done. So occasionally that group took recommendations back to board for additional resources to either be shifted in from other departments or to actually be contracted in, where it was becoming clear that there was a piece of work that wasn't going to get finished on time because of lack of resource. So there was no rocket science to it, really. It was just about having a oversight group that makes sure that all the momentum on all those really dull things that you have to do when you do an organisational change that can easily get missed because people are doing more interesting and more immediately obvious things, don't get missed.
Okay, great. Thanks, Nick. I've just got a reminder from Millwood just coming through on my text. When we speak, just make sure our cameras are on because we are streaming live on YouTube. And if you can leave it on all the time, if your bandwidth will allow, that would be really helpful because then it shows that we're in the room and participating. There was some, my camera was on but not on, but it seems to be working all right now. But if we can do that, that would be really helpful. I'll bring in Simon Kerr in a minute, but just before then, I think the other thing that will help with this is Susie Leather, who's the independent chair for the ICS, has requested whether she can come along and be part of our development session that we've got next week. I think that's a really positive thing. I think given the transition and given the sort of things that we've just discussed, a recognition that ICS and CCG need to spend this 12 months becoming much more closely aligned so that the transition is a smooth one, and an effective and planned one, I think will be really positive. So Susie being part of those and developing those closer relationships with the board and understanding some of the issues that we discuss and are concerned about from a CCG perspective will be really helpful in that process. Simon Kerr.
Thanks, Paul. I just wanted to remind everybody that despite the great success of the vaccine programme, we're probably still under halfway in terms of the vaccinations we have to do, and we need. I would like to understand what the sort of staff resilience plan is. I've got a lot of concern from the Eastern Collaborative Board yesterday to create more transparency for who actually are going to be the people who are being trained up and who are going to be able to continue to provide the vaccination service and the support service particularly, given that we are also going to be coming potentially out of lockdown. Some of the sites where we're currently vaccinating may need to go back to being proper tennis centres with people attending gyms and what have you. And also primary care may have to start standing up its QOF again from the 1st of April. So there's quite a lot of constraints that's going to, I think, play into the deliverability of the continuing programme, and I wondered how we're planning to mitigate that so that we've got staff that are resilient to carry on delivering the number of vaccines that we're going to be asked to do.
Yeah, so I'll bring in Darren. I'll give Darren a couple of minutes to coordinate his thoughts, but obviously the question came through, I think, on our staff webinar yesterday, Simon, as well. But for the benefit of the public, we have contingency plans, particularly around buildings. So we know that there are risks. We're currently delivering from leisure centres area. I think there are 2 areas that will be needed for local elections, and as you've said, other leisure facilities alongside GP practices having to stand back up some services. I would suspect, and I don't know this for a fact, but I suspect we'll get some national guidance on QOF to help support the continued coordination by GPs into the vaccination programme and provision through the GP practices. We haven't had it yet, but I suspect we will get some. But and I think there are 2,000 volunteers now in terms of vaccinators which have come on, and we've described this before. Coming through some of the checks has been slower than we would have liked, but however, as we move into this next stage of the vaccination programme, that actually might be quite well timed in terms of providing some relief. But if I just come to Darren for some of the technical elements.
Yeah, thanks, Simon. So on 2 points there. So absolutely. So we're working with each locality. So there are locality meetings now set up. First one's happened last week. There was an Eastern one earlier this week to really work with each locality to work out what the sustainable model is, because actually the model in West might be slightly different to Eastern, and obviously North. We have mapped all of the available workforce. So these are individuals, not just volunteers, but returners, so returning practice nurses, GPs, dentists, etc., as well as non-medical vaccinators. So we have a good workforce pool, and obviously our aim over the next week is to really work with each locality. I know that the contact has already gone out to each PCN about a week ago now to actually ask around what does the workforce model look like for each individual site. So I am confident working at locality level that we will have a resilient workforce going forward to sustain the numbers of vaccines, and obviously recognising the second doses will now start in earnest as well. In terms of locations, so we have Clive Shaw leading a dedicated piece of work around estates. I've already seen a model of a plan A, plan B, plan C in terms of buildings in the majority of localities. So again, I would hope that will be in a position to share with the primary care teams over the next week or so. And I think, the final thing that we have now got and signed off is a really robust modelling tool, which really starts to show the size of the ask against each of the cohorts down to cohort 9, and obviously then into the rest of the population now known as cohort 10, whilst we manage the all-important second doses as well.
Okay, Darren, can I just ask, because we've got some detail there, just for governing body, can you just describe what's in place to identify the risks, mitigate them, and then where's your route of escalation for any of these? Just because we've got a window here of where we're at the moment, but obviously it's a changing scene all the time. But just what's the process in place, just to give us the assurance that we can pick up those issues early and do what we need to mitigate them and escalate them.
Yeah, so the vaccination programme is running very much as you'd expect, a cell type process. So we have a daily operational clinical cell with a number of enablers, including obviously a workforce cell, finance cell, a pharmacy cell. That feeds into now a twice weekly, we were meeting weekly, but a twice weekly programme board chaired by myself, attended by system partners, where we have that check and challenge, and within there we have a system risk register, which is reviewed weekly on a Thursday. So that will be done again today, and ultimately then the route of escalation would then be through accountable officer, as in Simon, through to chief execs, and obviously anything that's significantly relevant to the CCG will obviously come through governing body.
Great. Okay, thanks, Darren. That's really helpful. David.
I was actually going to ask almost an identical question to Simon Kerr, but I just also wanted to draw attention to the fact that it's likely over the summer that we'll get some trial data about vaccinations in children, and it may well be we'll start getting more trial information relating to mutations, perhaps South African. So there is every chance that this vaccination programme is going to go on for the rest of the year. And what Simon was saying about fatigue is really important. I think there is huge enthusiasm to get this work done, and everybody's busting a gut, if you like, to actually get it done. But I do think that once we're no longer seeing high levels of illness in the community, we then need to move it into work as normal, part of normal workload. And the expectation that everybody, we're using the same workforce is not going to be so easy to sell once we're not seeing high levels of illness in the community, and if you like, an emergency setting. And as I say, we've also got to do the flu. We may well be vaccinating children. We may well be giving a booster in the autumn. All these things, it's going to need to be business as usual.
Yeah.
Yeah. Okay. Yeah. All right, John.
So thank you, Chair. Just exploring the low levels of illness in the community. I read this morning that Devon is now the most booked holiday destination in Britain, which of course is very good for the tourist industry. But do we have plans in place for managing contacts and infection rates, even though they may be very low, as our population increases during the holiday period? So if we have somebody who falls ill in a local area, do we have a robust track and trace system that's going to make sure that we actually contain any of these infections really as quickly as possible in people who may not live in our area? So are we looking ahead to living with low COVID?
Sorry, I was just because the local outbreak engagement boards cover this, and we've got two of our public health.
That's what I was going to say, Paul. That's fine.
So Ruth and Lincoln, that's probably most helpful for you to answer that, if you could.
Yeah, so from a Torbay point of view, I mean, we do have NHS Test and Trace, which should and has been doing the kind of cross-border follow-up for some time. We also have local enhanced contact tracing. I think Plymouth probably has. We certainly have in Torbay. We started that in late December. So we should have the capability, if information is shared with us, to be able to contact other areas and do that contact tracing.
Lovely, thank you.
I would just echo what Lincoln has said, really, to give assurances that, you know, the health protection system is certainly been exercised quite a lot over the last year, and we're absolutely planning to be able to live with COVID and to be able to manage those outbreaks as they arise and any new variants if they do become an issue for us.
Great, thanks, Ruth.
Great, thanks. And apologies, Simon, it's your report and I was delegating answers on your behalf when that should be left to you. So sorry about that.
So I'll take over chairing in a minute.
That's absolutely fine. I'll go and get a cup of tea. OK, anything else for Simon? Anything else you want to raise from your report, Simon? No. OK, thank you very much. OK, that takes us on to item 6.1, and this is the Northern and Eastern Community Services contract. Jo, I think you are starting the item, are you?
Yes, I am. Thank you very much, Paul. Morning to everybody. And Tim Golby as well is due to join me in the next couple of minutes. Obviously, Tim being the locality director for the North and East localities. So you'll all have seen, I'm going to presume you have read the paper, but I just want to set out really key context and recommendation for this, and then obviously happy to take any questions. So first things to say is this has been done in quite a lot of detail at both the commissioning committee in terms of understanding what we want from a service perspective moving forward. So what's the work we need to do between now and September to really be really clear about what we want to see in the outcomes framework and the specification, very much building, of course, on the work that we've done in the Western localities. We did have some quite detailed papers that particularly went to the commissioning committee, but as I've said, this has also gone to the exec, and members of the commissioning committee are here as well, so we can go through some of the detail of that if required. The recommendation that came from commissioning committee and endorsed by the execs as well to come here for approval is that we award a 10+5 contract, and that would bring it in line with the procurement that we're doing in the Western locality. I think really important thing to say is the reason why we want to do that is well, several different reasons, but the main reasons are that that's, of course, in line with our strategy around vertical integration that we've had for quite a long time as a CCG and a system, and indeed, of course, the Western procurement as well also seeks to achieve the same thing. Very clear this is in line with the long-term plan, and of course the recently published white paper as well. I think the other thing to say is this gives also, particularly since the providers are the incumbent providers, this also seeks to reduce any disruption as well at this time, which I think is an important point, but it's certainly not the most important. But this really does, obviously, as I've said, it is in line with our strategy and national strategy as well. We've looked at, and you will see some slides that have been attached to the paper which review quality and performance. So in some areas for community services, we don't collect data quite as robustly as we do within the acute, but certainly the indicators that we've looked at around things like admission rates nationally and locally, length of stay, some of the quality indicators around friends and family, all point out that actually overall, actually as a Devon system, we perform very well, but particularly in the north and east and the south, we particularly perform very well against those metrics. The only one I would probably point out, which is one of the areas we will want to continue to work with the provider on, is around delayed transfers of care. But of course, that's as much about what's happening outside of the services as well as what's happening inside. So it's as much a conversation as well with our local authority partners as well as it is, of course, with our health partners as well. So as I've said, there is quite a bit more work to do between now and September when we want to do the direct award. I think Tim has joined us, so he will be able to go into a little bit of detail about what we needed to do. And then the plan will be to take that work back through the commissioning committee. So when we went to commissioning committee last month, there was definitely a want to be briefed 3 monthly, but particularly leading up to the direct award, probably more frequently in terms of agreeing the specification, the outcomes framework, so that can have that clinical overview and sign off. And then in terms of assurance, I would recommend that this goes through the quality committee moving forward as well. So I'm just going to pause there and ask for any comments, clarifications or questions.
So, Joe, just before including questions, just clarification of what you've made a slight alteration to the recommendations. So recommendation 4, can we just adjust that slightly to say that commissioning committee will oversee the project, but that assurance processes will go through the quality committee? And if we just add that as item 4, I think that's helpful, because then we know that we're describing within the recommendations ongoing non-executive oversight and assurance within this process. That would be really helpful. Thank you. Lincoln.
Yes, thanks. I really applaud the long-term approach around integrating services and not having to chase the commissioning cycle too frequently. But I wonder about an 8-year gap between the break clause and coming up to the extension, and whether something formal should be built in, say, at about year 6, to give you flexibility and to kind of keep focus on the direction of travel. The other point I wanted to raise, particularly as you said, Joe, about the issues of delayed transfer, care, etc. What mechanism is there that local authorities and other partners who are part and parcel of that delivery system, how do they play into the quality assurance role? I'm not sure they're part of your quality committees.
Yeah, that's great. Thank you, Lincoln. So I'll answer the first question and I'll go to Tim to answer the second one, because he will want to talk about the local care partnership and how that's going to work and how the delivery of this is really going to be, they will take a key role in terms of the oversight of this. So I'll pass to Tim in a second. Just in terms of the first one, so yes, we've put in a 2-year break clause, but then after that, there's nothing to stop us any time also providing notice. So there's a notice period within the contract, and we can still do that. So it doesn't mean that after 2 years you then don't have an opportunity for another 8. At any point you could give notice, or of course you could mutually agree with the provider as well to vary something within the contract. So I hope that answers that one. So I'll just pass over to Tim.
Hello everyone, sorry I was a little bit late. You're ahead of time, so you caught me out on that one. Yeah, just a couple of things really. So I absolutely have confidence that the system is beginning to work collaboratively on some of this. So my sense is that we've got some more significant challenges around raising the profile of community services in the east than we do in the north, but that we now have established 4 by which we meet as a system, and that is beginning to change. The specific question that Lincoln raised around delayed transfers of care or discharge, I mean, there's been some fantastic work in both the east and the north through the COVID pandemic, where people have got together around, you know, a really urgent issue, and that work will continue with community service development and changes part of the thematics for each of the local care partnerships. So I think the contract itself will be part of a collaborative program of change, governed through increasingly the commissioning committee, as you just said, and the assurance there, but also through our collaborative partnership arrangements at executive level, through our delivery group arrangements, frontline practitioners, and increasingly informed by our stakeholder forums, which in the Northern Devon patch is one Northern Devon predominantly, and that's chaired by Dr. Walmsley, who's on the call, who can say more about that. And in Eastern Devon, we're increasingly working around a forum called ELF, Eastern Locality Forum, and that will have a range of stakeholder partners on it to get views to inform what will go into that community contract and the developments we need to see. So a real kind of 3 elements of the partnership: executive, professional delivery, and patient user feedback, to try and make a triumvirate that is overseen by the sort of assurance mechanisms you're talking about, plus also the executive of the local care partnership, which does include the provider.
Tim, that's really helpful, and I'll take it slightly out of order. I'll bring John in to sort of comment on what can happen in North Devon. Can I just ask, on the reflection that in the governing body before when we discussed Tinmouth proposals, we fed back what the Overview and Scrutiny Committee, some of their comments were, and there was definitely a desire from them for councillors and the council to be kept informed of processes along the way, and one of the opportunities we have around that is with health and wellbeing boards, and because there's a lot of crossover with our community services with some of the things that the health and wellbeing boards see as a priority. I wonder, Tim, whether on top of what you've just described, looking at processes of bringing them into some of that collaborative working with the local authorities would be a useful way of keeping our local authorities involved and engaged, particularly at that councillor level.
So I think the answer to the question is that yes, because if our members as democratic representatives need to be aware, informed and shaping that, don't they? I think our Eastern Locality Forum and the One Northern Devon Partnership deals with what I would call backbench members who are representing geographies and wards, the people that you and I vote for in the ballot box. I think it's a slightly different issue about how those politicians with executive responsibilities who make decisions are informed, and I think we've got some further work to do about how they're informed by the Health and Wellbeing Board, Paul, and also through some of the local care partnership executive arrangements. I think that's a bit informal at the moment rather than formalised, and we probably need to do a bit of work on that.
Okay, Tim, that's really helpful. I will bring in John at this point. I know it's taking hands out of order, but actually, since Tim introduced you around One Northern Devon, it might be helpful for you to describe what that might look like.
So thank you, Chair. I was going to make a completely separate point, but I might manage to weave the two in together. So I think I agree with Lincoln and with Tim that it's really important that we have this collaborative working way beyond just the NHS, the health services. So the other group that I would make sure we involve would be the voluntary sector, because some of the softer stuff around discharging and how people are supported in their community is really, really important. Difficult thing to measure, but we need to find some way to be able to gauge how good all our services are. And really, it was around that point that I was just going to mention briefly the friends and family test that is mentioned later on in the papers. And I suppose it's a constant disappointment that we don't have much higher feedback from what is really a very important part of our measurement around what our patients think, the patient experience around what's going on. And I was reflecting when I was reading the papers that when we spend 20 quid on eBay, we give feedback, but we get admitted into hospital or we get looked after by the NHS services, and very often people don't feedback. I'm not quite sure why that is, and maybe Andrew Millwood might be able to sort of comment on how we might improve that communications between ourselves as service providers and the NHS and the patient experience, because that's absolutely vital. If we're going to improve and change services, we need to know what people think of our services. So I'd love to see a much higher return rate on our friends and family testing. But getting back to the first point, I think it's really important that we have a broad view, that we involve our members, our elected members from the councils, the voluntary sector, and really communities, and how they might support people as they come discharged from hospital, or how they don't have to go into hospital in the first place. The whole system needs to be working together here, because people live their lives at home largely and not in hospital. So as much support as we can provide in our community services and from the community, within the community, the better services we will give to these people who need them.
Thanks, John. And Tim, I'm assuming that's the sort of thing you're describing, that wider stakeholder forum within the LCPs.
Yes, Paul. Yes.
Yeah. Andrew, did you want to come in around that sort of the patient experience and getting that user perspective in a bit more granular detail for these services?
Yes, thank you, Chair. I totally agree. Excuse me. I totally agree with John about the importance of doing that. So we're doing two things. I'm doing a paper for the April Partnership Board, John, on how we strengthen engagement, particularly with patients and the public, both at the system level and at LCP, more local level. So that's number one. And number two is we've started to talk internally between the communications team and the patient experience team about how we join up getting more intelligence around the patient experience. And it does go beyond, John, as you say, the friends and family test. We just need active patient data to support perhaps some of the changes that we're going to make as part of the long-term plan. So totally with you, John, and happy to talk that with you offline if that would help.
Great, thank you. Can I just remind people that when they are speaking, and preferably at other times, to make sure their camera's on for those members of the public who are watching. We've got quite a few. Can I take Glynis, Graham and Judy, take all three of you, and then we'll collect some points and then go to the exec team to respond. So Glynis first.
Yeah, just before I make the points I wanted to endorse what John and Andrew have just said. Very important to involve the voluntary sector, and there are some really good tools for collecting patient experience, things like I Want Great Care, which we could look at. The point I wanted to make really was about the quality assessment for these services, and I'm very glad that Joe says that part of that insurance process is going to come to the quality committee. The measures that we need to be beyond the performance measures to assess quality. And I've been told, Tim very helpfully told me that there's been an analysis, I think, by our team that there are no specific areas of concerns around quality. But I know, and I understand the RD&E had a CQC good rating in April 19, but I also noticed from that end of life care in the community was rated as needing improvement. So as part of the review that's proposed within this paper in the first 2 years, I think we should be looking very carefully at those quality metrics as opposed to performance metrics. And I would like us to assure ourselves that end of life care has improved since April 19. Sorry, long question.
Paul, I think you're muted. Did you want me to go next? Graham Turner?
Yes, I did. I said Graham and then wondered why you didn't respond, and then was about to tell you that you were on mute while I was on mute. So yes, please.
Thank you. Can I just check that people can both hear and see me?
Yeah.
I just wanted to make 3 points, if I could. The first was to build on the point that Lincoln made about the timescale. Whilst I too support a long-term contract and long-term stability, I do wonder if it's entirely sensible to set the timescale the same as the Western contract, because although I won't be here in 10 years' time, and 1 or 2 of us might not be here in 10 years' time, do we really want to be letting 2 contracts again at the same time in 10 years? Wouldn't it be better to stage them such that the workload on whoever's commissioning then falls into 2 parts rather than letting 2 big contracts at the same time? That was the first issue. The second point is about the break clause, and I'm particularly looking at the report and the criteria that it says we'll look at in terms of the break clause. And one of them is the development of an organisational form to ensure community services are given appropriate priority, for example, by having board level representation. I just wonder if we're in the danger of micromanaging. If I were on the contractor's side, I think I'd be saying to the commissioner, you can leave it to us as to how we establish our board and how we manage ourselves. You ought to be looking at outcomes and outputs and measuring that, not worrying yourself about how our board is constituted. And then the third point is really just a more fundamental one, I guess, about the break clause. Given that we read that both these contracts were given to single providers previously, and that we're keen to minimise disruption of services, I just wonder how much teeth a break clause really has in 2 years' time. This has got to be about partnership working and about making these services successful for the community as a team, whether you're a commissioner or a provider. So it's right that we have a break clause, but has it really got any teeth?
Thanks, Graham. And let's take Judy, and then we'll go back to the team.
Okay, so thank you very much. And building on the comments that have been made, I suppose my feeling at the moment is that it all feels horribly fluffy, and I don't have a clear sense of what the expectations of improvement are. And it feels almost as though we will be letting a contract before we are clear with them what we expect to have improved. So, I absolutely support the reasons for continuing a contract with these organisations. I sense that they are doing quite a good job in some of the material in the paper, but then I sense a whole mix of issues around where we want things to be different. I read that the quality is okay, but then I read that we want to do more measures on this. So it does feel horribly fluffy at the moment. And if somebody could say to me, these are the 5 things that we want to see changed, and then start working that into the reports that happen on this. So I understand there's a need for fluidity, but it just feels fluffy. And the other thing I wanted to be sure of is it's unusual for us as a governing body to be asked to assure that there will be enough staff to do something. So I'm going to ask the accountable officer to guarantee to us that if we accept this proposal today, he is going to make sure that there is sufficient staffing to do all the work that appears to still need doing in this proposal.
So I just answer that bit, Paul. So I'm comfortable, Judy, that we've got the right both skills and capacity to be able to do this. I've just reminded Joe that this contract wouldn't start till the 1st of April 22. So as you've said, it's I wouldn't say fluffy, but I'd say summary level at the moment, and we have a period of time to work with partners, including our GP colleagues, on what firstly what the baseline of some of the metrics are, but setting that improvement framework with very clear metrics out to support the break clause and the specification. But I feel comfortable that we've got the right skills and capacity to be able to do this.
Okay, so just to bring those together before we go to Joe. So Simon, that's helpful. So there is definitely something in here around how are we going to set the right expectations and therefore agree the right criteria to judge success or otherwise that will inform a break clause as and when it comes, or the processes before. So Glynis's approach that it goes through the quality assurance process is great, but what about something like end of life? And can I just bring in something that I think adds to that and then hand over to Joe, because on the first page of your slides, it does say the primary aim for many of community services is to prevent acute admission or to facilitate effective discharge. I'm just concerned that just perpetuates a very traditional view of what community services are there for. Glynis mentions end of life as one of them, but there are other things around chronic disease management, about maintaining independence, all of those sort of things that shouldn't even touch in and out processes within hospitals. And so making sure that we look at the broadest and what we want community services to be, rather than how they've been traditionally viewed through that acute lens. So Joe, it's just about how are you going to determine those? How are you going to have a proper process for agreeing them and then monitoring them and then applying them? And it then feeds, I suppose, then into Graham's point that actually what does applying them actually mean around a break clause?
Yeah, thank you very much, Paul. Thank you for the questions. I think actually that is a really good place to start, actually, in terms of what is the what's the overall purpose. And as you say, that absolutely isn't just about keeping people out of hospital. That's, it's part of it, but it certainly isn't. I think the issue is, and where we currently sit, and we know this when we've talked about out of community hospitals before, is the lack of data that we've got. And I think that's fundamentally where we are on this, is we're in the place where we need to start defining what those outcomes look like from a community out of hospital perspective. So what does that look like for a patient to keep people at home, to receive those services? How are we going to measure that moving forward? I think we've gone a little way to doing some of that within the procurement in the Western systems. I will remind people that we're not starting from scratch with this. So we have got a specification that we've used in Plymouth for the ICP procurement. We've also got an outcomes framework. So actually, there's quite a lot of work that's already been done. Yes, we need to do some work on that in terms of tailoring that to North and East, but my expectation would be 80%, 85% of that would be the same. So I don't want anyone to think we're starting from scratch on this, but there's absolutely a significant amount of work to do in terms of understanding how we want to describe those services in the future and what are the outcomes that we want to achieve from them, not just the impact that they have on a different part of the system. So Tim earlier on set out a sort of three-pronged structure. So the expectation is that the team will work as part of that LCP to describe what we want to see in that outcomes framework, what we want to see in that specification, and that as a partnership, as a whole system, we will get to input into that. So actually, we've got the opportunity for all partners to understand, what are the benefits we need to see from this. I think this very specific point about end of life, we will definitely pick that up, and that will be something that Tim and I will take away. I think the bit about the break clause, I think it's more about setting intent, isn't it? I think as much as anything. So absolutely, there is obviously an opportunity for us to give notice on the contract. We can do that, but going into this, that wouldn't be where any of us would want to be. So I think there is just something about intent, and there is something that us just being really clear from the beginning that this is how we're going to set this up. And actually, it's going to be a very rigorous process. There will be regular touch points through the LCP, through the local executive group, as well as internally for ourselves in terms of signing off the outcomes framework and the specification through the commissioning committee. So we'll have the opportunity through commissioning committee to make sure that we're including everything we would expect to see from a patient perspective, outcomes perspective, but also taking it back through the quality assurance route. There will be an opportunity to make sure that we, as a governing body as well, are assured about what's in there. And as Simon says, just linking back around to where Simon started, we have got a period of time to do that now. And as I said, we're not starting from scratch, so I'd feel relatively confident at this point that we've got the opportunity to do that.
Thanks, Joe. And you've just one of the things you've just added in there, which is over and above the recommendations, was that commissioning committee would be the place where those outcomes would be agreed and signed off. So is that, and I think it would be helpful for governing body if that was one of the things that we agreed today, because then we've agreed that there is a process for making sure that those, because that's a significant concern that a number of people have raised. Are you happy, Joe, if we include?
I would be happy. Yeah, I'd be very happy with that.
So that would then, we'd agree that as an additional thing within the recommendations. I will try and word those in a few minutes for us to sign off. Trying to keep to time, but I know there's a number of other hands. I just want to check those people who've asked their questions. So Judy, Glynis and Graham, just checking that you're happy with the answers that you have received on your points. Yeah. Okay. Let's take Sonia and then Simon, then John. We'll take the three of you and then go back to Joe.
Thank you, Chair. My point, and I'll try and keep it brief, builds on, I think, what we just touched on now, that understandably, because of the availability of the data, we focus on the benefits that this has on how our hospitals are used. I think I just wouldn't want to lose the point that I think a number of us just made, that really good community services also will have a positive impact in how the care sector is used, so long-term residential nursing care placements and long care packages of care, etc., which will then help with things like DTOC and everything. So it's a virtuous circle, but also then really good community services and the role that they can play in utilisation of mental health and other. So that is all in the outcomes frameworks that Jo has described. So I think she's absolutely right. We are building on a more holistic, just the data that is available to date really does focus on the hospital picture, and understandably so. So I think I just wouldn't want to lose that. This is really important. Getting this right will have many benefits way over and above the utilisation of our hospitals. But I think we touched on that already. Thank you.
Thanks very much, Sonia, and that's useful to know that there is that wider perspective. Simon.
So I'd just like to reflect, it's been an enormously helpful conversation with you all this morning. This is not a new issue for me, having spent a lot of time since we awarded the RD&E, the community contract in the first place, and also with closing a number of community hospital beds in the locality. We've had to think about how we deliver a lot of these community services differently. What I would be really appreciative of is the help that's being discussed here to get those markers for quality of community services really well established. And I think particularly around end of life, which Glynis mentioned, and also those living with dementia, but a number of other community conditions that we deal with, diabetes and asthma and COPD, pulmonary rehabilitation, that we'd love to have those things established in a sort of joint way with our community provider, much more with us in primary care than they are. I think I look at recommendation 2 in the 4 recommendations, it's agreeing an implementation proposal, and I look at the timescale we're looking at, and I'm sort of, I suppose I'm going to ask Tim as well. We've got a delivery group which is going to be key to this, and we've got leaders from our primary care networks who are keen to be involved. We need to involve lots of other sectors, as has been mentioned, but in order to get those really concrete proposals to the commissioning committee, we've got a lot of work to do, I think, to describe those pieces of work that will give us that assurance that the provider is going to really step into the community and work with us in primary care to deliver a different model to what we've got now. And it's going to be an ongoing piece of work with a provider that I think is currently quite secondary care focused. And it's interesting, those outcomes that I mentioned in the paper are to me very secondary care focused. We need to shift the outcomes that we're expecting to a very much more quality-based, primary care, community-based outcome focus. And that's going to be quite a task. But I really appreciate a lot of the comments that have been brought up this morning, because it will give us, I think, a different way of hopefully encouraging thought within our conversations in the delivery group in East. Thanks.
Thanks very much, Simon. I'll take John, and then we'll go back to Jo.
So thank you, Chair. So Simon, I couldn't agree more that there seems very acute sector based as far as the measurement goes, but that is all we've got at the moment. I'd have a request really, which is, we've talked about patient experience being something we should measure better. We've talked about the fact that we can measure the acute sector quite well. Can I suggest the third person in this equation is actually the provider, the clinician on the ground providing this service? And I would request that we think about building in a 360 organizational review process, because it's quite easy for the patient, no, not easy, but it's possible for the patient to receive a very good service because one part of the system really stretched itself beyond reasonable expectation to deliver that service. So I would love to have, in good system working, some sort of 360 review where different parts reflected how their jobs have been impacted by the behavior and actions of other parts of the system. That could be a great learning way for the system to develop. Thank you.
Okay, thanks. I'm aware, I do know Gaynor and Nick, you both got your hands up. I'll come to you next. I promise you've not been forgotten. So Simon, there is something there. I'm going to reflect back to Simon Tapley's assurance that he will make sure that there's enough resource behind that. One of the things I think from both what Simon and John have said initially is around is there the right clinical leadership within that working group? I know there's the commissioning committee, which has clinical presence, and whether that should be at place or whether that should be within the wider working group to agree these proposals and to make sure the implementation timeline is achievable and appropriate. and also to make sure that shift away from acute focus. So Joe, there is something around the implementation proposal, making sure it addresses those things and does so in the time allowed. And then John's issue around what are we doing to assess that it is that the staff, to take the views of the staff in this journey.
Yeah, thank you, Paul. I'm going to hand over to Tim just to, because I know Tim wants to talk about the group that we've got involved in this, including the clinicians, and how we take into account those views of the wider staff. I think, yeah, obviously just reflecting on the bit about, you know, we've only got the acute bit to measure at the moment. That's the piece of work that I'm kicking off at the moment with Kelvin and the community services team as well, just in terms of being able to get a baseline assessment of where we think we are with our community services across the county, not just in North and East, so we can start setting some baselines and then really clearly setting some measurements for this year. But I'll hand over to Tim to pick up John's point.
Yeah, thank you, Joe. So I think the delivery group that Simon referred to meets once a week. It's a call. It happens today at 12 o'clock, actually, our weekly call. It has a number of priority areas. Community services, one of them. I think this programme of work is the delivery of, it's that group's responsibility to identify that and deliver against it. We have to work together as a group. So I think we've got some network directors involved in that. Simon's part of that group, and describing what that group will be in the East, its work programme, how it will meet the timelines that we've talked about, and moves away from a very traditional preventing hospital admission to getting people out of hospital and the things that you're all talking about. That's the challenge of the group. So I think we've started general discussions, but we've now got a clear focus and timeline to make that much more specific and granular. I think in the North, John will know that we've got our integrated delivery group. It needs to focus on this as well, and it's got clear, specific, measurable things it's got to do, and I think that will bring some system ownership to that. Similarly, in the North, that has primary care representation. It has representation from all system partners to the architecture is there, I would say, to make this happen. Of course, people have got to want to make it happen, and that will be a challenge for all of us in busy lives. But that is what we will be looking to do in the next 2 years, and we'll start that once this is agreed as a process and an approach.
Great, thank you very much, Tim. Let's take Nick and then Gaynor, and then we will move to the recommendations.
Thank you. Just feedback from the commissioning committee. I largely agree with everything that's been said. We were really keen to see all the quality and outcome metrics, and we'll be keeping a very close eye on that as has been requested. And clearly we can escalate back to governing body. The only issue I have with this is that to get good metrics and good measurements is, as Simon said, going to be a really big effort in a short period of time. And I think there's a risk that we will struggle to get what is we deem really satisfactory measures in place in that time. And the question is, what do we do then? Clearly, the commissioning committee can escalate back to the governing body to discuss, but what are we going to do if we don't really get that? Because the commissioning committee were quite keen that we really did push the quality stuff, and rather than just reletting a contract to a provider that's already doing it, we wanted to see some definite improvements. But it's an open question. But we'll keep an eye on it. But just what do we do if we don't get there satisfactorily?
So I think Simon's got his hand up probably to come back on that, but let's just take Gaynor first, and then Simon, I'll bring you in.
Thank you, Paul. So I agree with what we've been talking about. I feel that I've had some assurance, but Simon, if I can ask you, you said you're confident that we have the capacity to deliver regarding staffing. Are you basing this on investing in more staffing for the community, or is this based on the current staffing levels?
So I think the question from Judy was, well, so how I've interpreted it. So if I'm wrong, Judy can come back. As a CCG, have we got enough staff to be able to do what we need to do to have a proper specification and manage the contract? Okay. Not about do we have enough capacity capacity in the community to manage the patients in a different way? That's a different question.
No,
so
that's fine.
I would have less confidence in that second question, but that doesn't mean we shouldn't be able to do something different. I think there's something about how we have our model of care. So I was gonna come back to I'm trying to look around. I've got the big screen on now, so I can see everybody. But Nick's point. So I think we keep saying we don't have the same level of data as we do in acute services, and that's true as a commissioner. But we miss the fact that as providers, there's lots and lots of information and data for each individual service. So, you know, I know Gaynor is a team leader in North Devon. I bet you've got all the stats for the patients and the teams that you're managing in terms of waiting lists, caseloads, etc. So where we have an issue is how we collate that at a commissioning level rather than a provider level. So I don't think we are starting from nobody collects anything at all. So that's one point about how we could do better. I think population health management is going to be really, really important in this, because that gives us the opportunity to have data from GP practices, social care, community services, acute, into a dashboard, if we can't think of a better word for it by then, and actually make sure that we are managing at PCN level the right sort of interactions with community mental health teams, adult social care teams, our own community teams, etc., etc. So I think there's a piece of work to do about how we draw that together. So Paul and I, just on the last bit, Paul and I had a very brief conversation this morning that I think we all think that enhanced primary care or primary and community care is the right way to work. But we shouldn't miss out the fact that what we're trying to achieve is keeping people healthy and well and managing them from going into crisis. And if we can support them from doing that, and if they do go into crisis, we get them out of crisis and back into independent living as quickly as possible. That's why we count it from an acute lens, isn't it? Because the crisis tends to end up in institutions. So I think we shouldn't just throw away the fact that because it's community services, let's not have a lens of acute, because that actually is the output of a crisis, isn't it? Is when people end up in institutions. So there's some work to do, but I am quite confident that having run through this in the ICP process in Plymouth, that we've got a good basis to build upon. And the other thing I was going to say, Paul, actually, is that I think as a governing body, we should ask for a progress report on this, not just leave it to commissioning committee and quality assurance committee. This is a big piece of work. We should ask for an update, I think.
Simon, I think that's really helpful. Okay.
I just had one more point, and again, it's just something that you brought up, Paul, is just about the slide that says the primary aim of many community of services to prevent acute hospital admission and discharge. That's one area of what that they are responsible for. So there's a lot of other work that goes on in the community. So that's just one element. So that's not their main aim.
Okay. So I think what Simon's saying is we can use the acute process as a marker of how effective, even if it's not their aim or their primary outcome, it can easily be a surrogate marker of how effectively they're operating. Yeah, absolutely. Okay, so we're going to conclude the recommendations. I think are altered slightly. Joe, just within the before we do the recommendations, when can we get a progress report coming back to governing body? And I think it would be useful to get that once you've got a tangible set of tangible outcome framework that we can view and take a view on, that's been through commissioning committee. So it's getting a sense of when that is likely to be.
Yeah, so my suggestion, and Tim can vigorously shake his head if he's not happy with it, would be May would be appropriate to see where we've got to in terms of refining the outcomes framework and the spec that we've got. And then we should also be able to give an update, I think, then in terms of where we are in terms of our plan around baselining some of the data that we've got for our community providers.
Okay, that's great. I can't see Tim on my camera, so I can't see whether he's shaking his head. So I'm going to take May as a good sign.
He's very still.
So okay, so let me see. The recommendations should be. I'll read them as I think. If we take what I say rather than what's written, and then Nikki can adjust them if you could please after the meeting. But the first one is, as it stands, to make the direct award of a contract for general community services to RD&E and North Devon for 10 years with a potential 5-year extension, with a clear proviso that contract will be terminated after 2 years if satisfactory progress is not made on a number of defined issues. Number 2 is to agree the implementation proposal as set out in the paper, including, firstly, the agreement and approval of the outcomes framework to occur within the commissioning committee, and secondly, for an update including those agreed outcomes to come to governing body for assurance in May. And then the third one, as it stands, agree senior leadership for this work to be prioritised to ensure sufficient resources available to deliver the required outcomes. And fourth one is to agree commissioning committee will oversee the project, receiving updates no less frequently than every 3 months for the next 3 years, as will the quality committee, to provide assurance and non-executive oversight of the quality issues around our community services. So I think those seem to be catching the main key themes. So can I just ask people, because the public can't see the chat bar, we won't use the chat bar to use whether we vote, but I'm going to ask people to vocalise if they feel that they cannot approve those combined items and recommendations. And I'm going to ask people to vocalise if they feel they need to abstain from the vote. Okay, thanks, Nikki. So that's unanimous approval of the adjusted recommendations as just described. Thank you very much. Thank you, Joe. Thank you, Tim, for all your hard work on this, and not least because it sounds as though the hard work has only just started. Okay. We are now moving on to the Assurance Committee updates. First of all, finance and performance. I'm going to first, there are no items that you've got for escalation to the governing body, Graham, but I'm going to ask you whether there's anything you want to highlight, and then if not, pass over to John if there's anything that he wants to draw out.
Thank you. If I could just highlight a couple of things, Chair. Just on the finance side, pleased to say that we're forecast to balance in the current financial year, but colleagues will know that these are unusual financial times and we'll be back into the normal financial regime next year with the normal financial challenges for which John and his team are doing lots of preparation. On the performance side, again, familiar topics for governing body, issues such as the cancer treatment waits, particularly at RDE, the 52-week long waits, ambulance handovers at UHP, and the performance of the 111 service are all issues that have been before governing body before, many of which are also in the Quality Assurance Committee report. And then the final issue is that the Chair, the committee asked that in future whether the way quality and performance reports are presented could perhaps be reviewed, and this actually ties into the review that you are wanting to do about how we triangulate finance, performance and quality together to give a better picture for governing body. So there's some synergy there between what the committee has asked for and the work you've undertaken. Thank you.
Thanks, Graham. And for the committee, for governing bodies information, I met with Graham and Glynis, as well as Darren and John, to discuss how we make sure that governing body has appropriate oversight of key quality and performance and finance issues, whilst making sure that the bulk of that assurance process happens within the committees. And Ginny, apologies, Ginny, you were part of that as well. And so Ginny is working with, particularly with the two chairs of those committees, to work out what that looks like. So we may well see changes or some trials of different ways in which we try and get that balance right. So please do bear with us, but rest assured that both committees are providing that assurance process on behalf of governing body at the moment. John, anything for you? And then I know that there's a couple of hands being raised.
Thanks, Chair. No, nothing to add to Graham's report. Thank you.
Okay. Simon.
Thanks, Paul. I just wondered whether we could ask Graham to ask if we could have some information about referral data, because referrals obviously lead to demand that then potentially leads to delays. So we need to see, I think, referral information. And are we anticipating a massive growth in referrals, do you think, once we ease out of the coronavirus pandemic?
Well, I guess. Sorry, Paul.
Sorry, Graham. I was just going to say, I think at this stage, Graham, can you just clarify whether that is being covered in the assurance process within that committee? Because, of course, what we bring through then to governing body, rather than trying to do that without the information in front of us now, will be something that will be part of that work we've just described.
Certainly, referrals is picked up in the reports that come to the committee, and I guess the members will have access to those reports should they need them. I think we've got Jane and Darren on the call. They'll be able to give more information than myself, but I guess we only have to look at the long waits figures to know that, you know, those will transfer into referrals as we come out of the second wave.
So I'm going to ask just for this governing body for us just to be comfortable with the assurance that that is happening, rather than having a sight of it at the moment. But we will hopefully next governing body have something that bridges that, as we said, between governing body and committees, the information that should be seen at each meeting. James.
Yes, thank you, Paul, and thank you for the report. I just wanted to ask about the shift from month 7 to month 8 in system capital spend. It went from 2.9 million under plan to 4.7 million over plan. Just wanted to ask for detail on that, please.
I'm probably going to defer to John to answer the detail of that question, if he would.
Will do, Graham, thanks. James, it's just a bit of month-on-month variation. The sort of nature of capital spending is it's quite lumpy, but our important thing, I think, is that our year-end forecast position is that we're on course to deliver capital spending in line with plan, as we are with the revenue position. So no cause for concern by the time we get to the end of the year.
Thank you.
Thanks very much. Thanks, James. Thanks, John. OK, so let's move on to the quality report. And again, you haven't got as much sight of the quality information as we would normally have, but that's in reference to what I mentioned earlier. But Glynis, for you, anything that you want to highlight from your report?
Actually, there's nothing I want to add to the report. I think it's a good summary of the discussion we had at the meeting.
OK, thanks, Glynis. Alison, you want to come in here?
Thank you, Paul. Glynis, I just wanted to check. You refer to the Young Devon engagement report about assisting families who are waiting for an ASD assessment, and they highlight some really good recommendations, but it doesn't say if those are being taken forward in any way. So are you able to help us with how that's being taken forward?
Yes, they are being taken forward by the steering group that prepared this questionnaire and this survey are going to continue in place and ensure those recommendations are taken forward. And we also asked that the report come back to the Quality Committee after a reasonable period to see to the extent to which they've been implemented, because we want to make sure, because they are great recommendations, but they do need to be implemented. You're absolutely right, Alison.
Thank you.
Thanks very much, Glynis. Judy, Primary Care Committee report. Anything you want to highlight?
I only want to highlight that we discussed at the last meeting, going back to Simon Kerr's comments earlier in today's meeting, the issue about the sustainability issues for primary care in managing the mass vaccination programme, and we're expecting a report at the meeting next week.
Okay. Thank you very much. Thank you very much, Judy. And I can't see any hands being raised, so we'll move on from there. I'm going to take commissioning committee paper as read, as the chair isn't part of this committee. And then local care partnership updates, I'm going to take those as read. I think just helpful for the committee to understand. So now for the partnership board of the ICS, each local care partnership provides an update for that board. What we have agreed is that that update would be what is used for us to understand what is happening within each of our local care partnerships. But what we would do is each month we would ask one of our locality directors to join governing body so we could have a particular focus on the localities that they work in. So we haven't got that this month, but next month we, in my memory, will have North and East. So I think Tim is joining us. And so we will have all of the reports available at the governing body, but we will have an opportunity to discuss in a bit more detail those two particular reports, and we will rotate around our geographies with each governing body. So we take them as read unless there are any other specific comments, because I'm aware that the authors are not present here within our governing body. Nick, let's take your comment and then over to Judy.
Thank you. Well, it's just going back to the commissioning committee report, which I normally report on if necessary. There was one small point I just wanted to bring to the attention of governing body. It was just it's something that was picked up that the commissioning committee changed, approved some minor changes to its terms of reference, and whether that was something that it could do without governing body approval. Ginny was asked and said she thought that was fine because it doesn't, commissioning it doesn't have any specific delegated decision-making function. But I thought I would just bring it here to highlight it, that the changes to the quoracy were agreed at the commission committee. They were pretty minor. It reduced the number of executives from 3 to 2 and changed the wording of the clinical members who needed to constitute a quorum. That was all it was. I just wanted to highlight that.
Okay. And we'll take Ginny's advice on whether that could be done without governing body. But I think what might be quite helpful is just so that governing body are aware of the most up-to-date terms of reference for that committee. I think it would be helpful just to circulate those for information rather than for necessary approval. But thanks, Nick. Judy.
I just wanted to raise, in terms of the localities, the fact that we have the new localities, except in the West, which is not reported on in terms of its locality development, its LCP development, but is reported on as if it were still the old Western locality that we have. And because I am particularly concerned, as I've raised before, about how the West is going to be able to develop good locality working, I wonder if for the next meeting we could make sure we get a specific report from West locality as opposed to old CCG Western. Is that making sense?
Yeah, so we will do, Judy. It's a timing issue that the other 4 locality reports had been done and completed and submitted to the partnership board for next week, and the Western one is still outstanding. We haven't had our first West LCP meeting. It's scheduled, I think, for next week or the week after, but absolutely we'll get a report here for next time.
Great. And that reinforces my concern that West is somehow tailing behind. And it is very important that, having made them into this mini LCP, we are very supportive of them and almost help them become first in most of their reports.
Yeah, point noted.
Okay. Thanks very much. Thanks. It's a really important point, Judy. Thanks, Simon, for that clarification. So we will look not only for them to report in the same way that others, but also for their report to demonstrate the resource and work being put in to help establish that as an LCP. I think that's probably one of the key things that we should keep an eye on when we see these reports and gain assurance that that is happening. John.
Thank you, Chair. Not that I'd ever tell the Chair what to do or the system what to do, but so I'm wondering whether, following Judy's comments, the focus should be on the Western LCP. I don't know, but I was going to make the point that we always seem to put the North and the East LCPs together as one, because Tim has the unenviable task of being our Associate Director. Could I suggest that maybe those two parts of the system, although they need to work well together, are actually two separate LCPs, and it doesn't really seem appropriate to lump them together. That I think if we're going to focus on LCPs, let's focus on LCPs, not the associate director.
So I think you're absolutely right. Each month we're going to focus on 2. But we're going to do it in a way of only asking one director. So, for example, we will do South and West together because it's the same associate director. And what we'll do when we look at Plymouth is we're also, because mental health is a care partnership, although not a geographical one, we will look at bringing something in around mental health for the time when we're looking at Plymouth. So it's not a matter of trying to fudge it and just look at the 2 as one, John. I think it's each month we focus on 2, and we do take them separately, you're right, rather than just a single unit. Yeah.
Thanks.
Nick Ball.
Thanks, Chair. My point leads on directly from what Judy and John were saying. Could we have, it doesn't necessarily actually have to be for the next board meeting because this is purely for information, so it could just be circulated. But I'd like to see something that summarises the locality structure now. So there's two things I'd like really. I'd like to understand, because I don't understand it, how the locality relates to the CCG and how the locality relates to the ICS. And I'd also like to see the membership of each locality board for all the localities, because I haven't got a clue who's on the boards. I've got a vague idea who's on them for the West, but I haven't got a clue who's on the locality board for the South. And I just feel I've really lost a grip over what localities are about at the moment. And that doesn't feel like a comfortable position.
So Nick, are you asking for, so I got the second bit, so each of the 3 LCPs, so let's use LCPs rather than localities. I'll come back to why I'm asking that question or making that distinction. So each of the LCPs has an exec group, a delivery group and a stakeholder group. So we can certainly set out who is represented on each of those 3 groups. We've then got a locality commissioning team that supports the work going on in the locality, and that's probably to draw attention to Judy's point even more than we have done before. Some of the West Devon work is supported by the Plymouth locality. Some of it is supported by the Southern locality, depending on which elements it is. And, that's mainly around acute trust, around urgent care, for example. So we can certainly set that out. Is that what you were after, Nick? The membership of the meetings? Yes. And the key bit, in case you didn't hear what I said, Simon, I like to understand what is the relationship between those groups and the CCG and the relationship between those groups and the ICS. Okay, so I think so that's fine. We'll do that. Okay, cool.
So a lot of that has been through the ICS Partnership Board, hasn't it, Simon? So that information should be there, and it should be relatively straightforward to share that with governing body, shouldn't it?
I think if we're bringing, if Tim's coming to the next board meeting, I think we can. I know we want to focus on the North and then the East LCPs, but we could use some of that as an example of how that's working, because there is some consistency across the localities. But we'll do that. And do you want that in an email out to you rather than in a physical board meeting or a development session? I'm very happy to receive it by email, and then if I've got hundreds of queries, perhaps we could take it at a development session. Okay. But I sense that I probably won't have loads of queries. I just have never seen it laid out in one document. I just the relationship with the CCG we have never written down, so that's not why you haven't seen it. Yeah. Okay. Great.
Simon, I think that would be helpful. I think the idea in the first instance is sending it out electronically and using North and East as a test space for feedback from the governing body with Tim present and at the next governing body would be useful, and we can then get a sense as to whether we need to spend some more time in development looking at that. So that I think that'd be a useful way of doing it. I get John's point that maybe we should start with the West. It was pick a place to start, but bearing in mind that we will be circling through them every 3 months, so we will have quite frequent quarterly reviews of all of our areas. Graham.
Thank you, Chair. I have a question which arises from the the Northern Locality report, but actually it's a question about the whole of Devon. The report tells us about the continued closure of the Ilfracombe and Bideford minor injury units. So my question is that an issue that's playing out across the rest of Devon rather than just the north? What's the impact on patients and GPs who are providing cover? And secondly, it's sort of stimulated a question that goes back some long time about the review of urgent care and the sort of levels that we were going to place in certain areas and the nomenclature we were giving to areas, whether it was same-day service and minor injury units and so on. I think about a year ago we were looking at that. Has that piece of work been stood down because of COVID and all the pressures?
Yeah, it has, Graham. So the community mental health, the community urgent care strategy, and particularly those elements were a piece of work that we had to stand down in terms of dealing with other issues. But it is coming back up the agenda again, and we've asked Helen Bailey alongside Tim to do some work around that. North Devon is not alone in that. There are a range of minor injury units that were closed in the South Devon and Torbay patch, but through a formal consultation process.
And the impact on patients and GPs?
And John Walmsley, I know, is bound to come in and talk about that. So we haven't had a lot of adverse reporting coming through to me, but I think that needs to be part of the review.
Thanks. So I'm just aware of time, and rather than opening the door for a lengthy discussion about urgent care, I think maybe it's something that needs to come back with a bit more information in front of us around sort of MIUs and the current position within out of hospital urgent care. Simon, although Jane's Jane, you've got your hand up. When would be appropriate to try and bring something back that gives us the space to have that informed discussion that we've just started now?
Probably better off asking Mr. Finn, I think.
Mr. Finn, John.
Sorry, John Finn, sorry.
Okay, we could certainly brief him any point in time now. Actually, there was a masterclass at OSC a few weeks ago that brings us right up to speed. So just at the governing bodies, the leisure, we can do that.
Okay. Well, let's aim to, if you've got something that's up to date, let's do that as soon as possible rather than leave it a few months when it then becomes out of date and you have to redo it. So let's put it in for next month.
Okay.
And then let's have that discussion. John W., given the time, was yours about urgent care?
Just to be very clear, these are temporary closures of MIU units that was brought about by staff challenges during the COVID crisis. So it's a temporary closure. We have good mitigation in place. We've had long discussions with the local PCNs and the GP practices, and they've been very happy to take on the extra work. And we've involved communication with the ED department and NDHT. So I'm happy that actually this is a good, safe, secure, temporary solution. And as John, Finn, and others and Simon was saying, there are conversations just about to take place around the longer term issues, but this is a temporary situation at the moment. Thank you.
Thank you for that assurance, John.
Right. Okay. Thanks very much. In which case, I'm going to close our public meeting. Welcome and thank you to anyone who's been part of it on YouTube or is watching it on playback. Thank you to all of you who've attended and participated and contributed. The private governing body is going to start. It is due to start at 11:45. Let's do 11:50 so people can get their 15 minutes break. For the GPs on the governing body, including myself, if you can be ready to rejoin at 12:15, But keep an eye on your emails, and I will ask Nikki to send through an email to all of us inviting us to join when that discussion is over for the first item. Nick, is there anything you want to say about that first item before we break? No.
You're on mute.
You're on mute. Nick, you're on mute.
Sorry, it's about 100